Thanks very much, Yvonne, for a controversial introduction, but I'd like to say I'm probably non-partisan in one way. I'm half a Mayo woman, but I was born in Galway. I'm really a Galway woman at heart. But now that Galway's lost to Clare in the hurling and we're out of the football, I think all our cards are on Mayo. But we had our encounter last year. It wasn't so good. Today is my second time in Donegal this year. And let's say our paths will cross again. So we'll see about Sunday. However, tonight I think it's a little bit more sombre. It's nice to have the football to distract us, really, isn't it, from the realities of our situation. But I'm afraid we have a serious topic here to discuss or to debate. And I wish to thank Joe Mulholland, indeed, for inviting me to speak at this eminent MacGill Summer School among such distinguished speakers and guests that have gone before me. And wow, have they given us some thoughts. It's an honour for me to be here and to have an opportunity to share my experiences and beliefs in current health and social events that have developed over the years that I have been practising as a GP. I suppose since 1985 I have been a GP in Mayo, and also since I was appointed coroner in the early 2000s. So there was an idiom said years ago, no one cried stop. This was said by a Mayo man, maybe some of you might remember John Healy. And when immigration and desertion of his county and town lands took place in Charlestown, and there was social deprivation and break-up and breakdown as a result. But now it's time to say stop again. Enough is enough. It's time to say stop again to the IMF and the Troika and our government, our legislators and ministers, and the HSE, I suppose, in their bureaucracy, to stop the major cutbacks in healthcare, so that they would honour their commitment to support and invest in primary care by way of stopping the job embargo and slashing of support to providers and professionals. There's no need for no more strategies on health reform to be produced unless there are fundamental basic services put in place. By further cutting the funding to general practice, the cornerstone of primary care, the HSE with the Department of Health are fundamentally dismantling the fabric of community medicine in this country and putting the future of general practice into jeopardy. General practice only receives 4% of the total HSE spend on an annual basis. Yet 92% of all clinical cases are seen in primary care setting. Therefore, is it not good economic sense to invest more at community level at the point of delivery of this care? And that means for every one of you that are here today, at the point of delivery of this care means your GP in his surgery, in a primary care setting. As I've seen coming in here, a lovely primary care building there with all services available at it. That is what's worth investing. So in a sense, people would get the spin from the media and from certain departments that, the medical professionals are creaming it and that we're all, rolling in it. But in actual fact, the actual truth is not so. At the moment, there's universal health insurance being promoted as being to be rolled out in the reform. It does have its attraction in that it has equal access to care for all. But do we really want to pursue an NHS-type system where patients are expected to wait up to 3 to 4 weeks to see their local GP and get 5-6 minutes of her time or his time? In GP at the moment, there's only one tiered system because there's equal access for public and private. However, people do have to pay that are private, and those on GMS are limited in a sense in that they have to apply every year for a medical card and they're only dependent on their limited earnings and so forth. But in a sense, it does make a difference, and that if universal health insurance gets in the road, there'll be waiting lists. And really, is that what people want to say? It is gratifying to hear from previous speakers, and I think it was maybe Maureen Affine that said that 90% satisfaction and trust is present in the people today, in their GP and in their medical profession. So that's what we'd like to hold on to, and that's what we think we should matter. My interest in medical affairs stems back into the 1980s and 1990s, when general practice only then became recognised as having an important role in sustaining a health service. I sat in many committees in Mayo, GP faculty at the Irish College, and as a GP in the primary care unit development on women's health and indeed in domestic violence. And at that time it seemed to be very, very important that women's health was forgotten about, didn't know, that we would campaign locally for better services. And happily to say that is true today. We did improve that, and we do see the result of it. Of course, the country was awash with money then, wasn't it? There was money for everything. And yet, was it well spent? Did it really produce the goods we wanted? I don't think it did. But recently, Dr. Matthew Sadler, President of the IMO, of which I've been an active member for over 20 years, said the Irish Health Service could learn from the British Medical Association in lobbying for medical-style regulation of health service managers to ensure that they are held to account for failures of their NHS Foundation Trust, and to demand a sea change in the NHS culture, that patient care be the first pursuit of all involved in healthcare. And I think this is the motto we should adopt as medical professionals now. Where is accountability and responsibility for actions held and done? Well, this is not the case, as we see more and more layers of administration, new posts created, added to the HSE Department of Bureaucracy, and in the name of Primary Care Department, causing more barriers to access health services than there were many years ago. New models of healthcare are being rolled out now. There's reform without basic services put in place. New documents such as Healthy Ireland, recently launched by the Taoiseach, shows that health is dominant in the programme for government. But is it idealistic, aspirational? In the present economic climate, is it utopian? It is impressive to see it high up on the agenda, and it is holistic, and I do commend them on producing it. But in a sense, is it realistic at this present time, unless the funding is put in place? There's now currently more regulation of professionals, and during the setting up of HICA and increasing the powers of Medical Council, more litigation and complaints against doctors, which actually alter the doctor-patient relationship. Higher patient expectations put more demands on services within primary and secondary medical care. So there's more pressure, more stress, and more referrals. Is this the way we want the future to be? Examples of this can be seen on a daily basis in our surgeries and practices, where access to medical care, as in getting diagnostics, hospital outpatients and admissions, and waiting lists are increasing for all. This is proving more difficult to operate in, and I'm sure all of you have had experiences in this, and yet we keep trying and striving to overcome these obstacles. However, the widespread cancellations and culling of medical cards of cancer patients in this present time, and elderly patients unable to complete reams of forms requiring personal information, to me is non-excusable, and it's another cause of stress and hardship to our patients. Patients denied access to old age psychiatry because they happen to be getting older, somewhat dementia, query Alzheimer's, because they're living in a certain area in my county. It's actually living in my area, and they're not in the sector of the old age psychiatrist in my area, is one example we see happening, which defies all logic of fairness and equity in the health service, which is, what is the strategy is promoting fairness and equity. So I think these are issues I think we need to speak about and try and address. I see my role as a GP and coroner for North Mayo as a constant advocate for patients' health and safety, becoming a struggle to cope with change and chassis, I would say. It's chaos at times. It's a battle to obtain basic services to meet the needs of our young and old. And this can be draining and frustrating at times, but actually rewarding and very fulfilling at other times. And overall, it's a worthwhile challenge. And so on that hand, the positive changes and improvements seen over the past decade include cancer care services for breast, prostate and lung cancer. Fast access has actually proved successful to reduce the rate of death, mortality rate, and increase survival rates. Of course, the emphasis on prevention medicine, the anti-smoking campaign, and the vaccination immunisation had proved great improvements. And I also welcome the arrival of the aeromedical services for our remote areas. And I believe this actually happened in recent times, and with the Minister of State, Kathleen Lynch, up in this area, and that she was able to be removed and taken successfully down to a hospital to treat her condition, and I wish her a speedy recovery. But indeed, we see this in operation in the west of Ireland, in MacGill, in remote areas, and it is wonderful, because we have been looking for this for many years. Tribute to Jerry Cowley, his GP in MacGill, that campaigned for it. But now we have speedy access for patients with stroke, heart attacks, head injuries, being fast, tracked into third-level hospitals, tertiary care. However, on the downside, I'm dismayed with the downgrading of our local hospitals, because there has been a reduction in community health staff and nursing staff, essential to keep beds available for acute admissions, especially respite care for our rising elderly population, because there's cutbacks in home help. Where do they go? Where does our people go when there is, trolleys in the acute emergency unit, and they're in elderly condition and they really just need supportive care? This is the problems that we are facing at this time. So accessing clinics as well as mental health services have become increasingly difficult. And there are more barriers corrected by our administration in the health service than there were 20 years ago. And why is this? How many of these new officers and layers of administration have provided care at the front line on a personal level, or indeed to know how we operate on a daily basis? So what is the solution to our health crisis? The Department of Health and the Government need to listen to many medical organisations and healthcare professionals, including the Irish College and IMO, who raise serious concerns for the future of general practice and patients as a result of the major cuts in funding and resources. The impact of these cuts will lead to increased hospital referrals, increased A&E attendances, reduction out of hour services and longer waiting times. So how can it be possible for the Department of Health and HSE to implement their health reform programme if they continually undermine the very resources that are expected to implement the new care models? We need to work together to bring about change and implement these programmes of care in a fair and equitable way. Our role at general practice as a gatekeeper and advocate for our patients should be forgotten, as so often it falls on us to solve the multiple problems sickness can cause. As Ivor Brown said recently, and I quote, "We put hospital consultants on top of the health pyramid when it should be GPs at the top. As in primary care, it should be funded more in order to reduce the emphasis on hospital care, and that prevention of disease is better than cure. General practice is the bedrock to all health services, and this has to be recognised." Now, finally, just to move on to, I suppose, a more emotive subject and indeed a more sensitive issue, the recent publicity and media spotlight on the high rate of suicide can be, I suppose, helpful but not really effective in reducing the incidence of it this time. There can be no generalisations or speculations as to the many causes, as it is a very unique personal tragedy, sensitive to those who have been at the other end of it. In my area, the impact is rising in suicide. Over the past 5 years, based on the figures from an inquest held in 2007 to 2012, suicides have doubled. In the 1990s, there were 43 suicides. It's a small population in our area, Mayo. There were only 43 suicides of all the inquests that were held in that time. There was 109 in the year 2000 to 2010. Indeed, this is borne out by the data released recently that County Mayo has the third highest instance of suicide in the country. This is quite alarming. So Ireland also appears to be the only country in Europe where youth suicide continues to rise. Mental health problems and related illness make up to about 40% of our workload in general practice. So how then do we predict with limited time resources, what patients are at risk. Psychotropic drugs are being prescribed more frequently now in general practice because we have no immediate access to CBT, which is cognitive behavioural therapy. Counselling is available, but at a limited rate. It is difficult to access mental health services. If one needs a patient is in crisis, experiencing suicidal risk, it takes a lot of phone calls, it takes a lot of knocking at the doors to get help. So I think at this stage, self-inflicted or self-harming and self-inflicted death is a huge area that research has been done on. There's many offices like the National Suicide Research Foundation and suicide prevention office set up, and it is laudable indeed that the current, that the Taoiseach government has paid attention to this. But I think it is quite alarming for me as a coroner and as a GP to witness the number of suicides in young teenagers over the last 10 years as I've been coroner. And it is so distressing as a parent myself of experiencing and not even sharing, but accounting parents who have lost their sons, their daughters, 14, 15 years of age, for no apparent reason. There's no accounting for a lot of the suicides. Nobody can really say what caused it. It is sometimes linked with recession. It is linked with disconnection. It can be alcohol-based, as 40% of cases, but in a lot of times there isn't a cause, and nobody can explain it, and that is the awful thing about it. And I think what's shocking myself is the method used by the majority of cases, in young and old, is that 60% are hanging. This has caused so much distress to relatives and health professionals who witness it, and to hear the evidence given by their partners, by their sons, daughters who have come across it, it is hard to recover from. It appears to also replicate in copycat, as you have seen in Donegal and indeed in Mayo. There has been a sequence of copycat suicides, and that may be something that we're not connecting with our young people because of interference from internet, Facebook, Twitter. And many of us can really know what our sons or daughters are talking to or listening to online. It is a difficult place to be as a parent as well as being a young person. Such like loneliness, isolation, rejection by friends, unemployment, relationship problems, all those issues are associated factors. And indeed there's a connection with being in an isolated area, like as in Donegal would have, North Mayo has as well. But alcohol in itself is really a depressant and a drug that is consumed by too many, too often. My esteemed father-in-law and colleague, Dr. MacGill Loftus, spoke out against abuse of alcohol here, I'm sure, in this school, and in many places, in sports and GAA grounds as well. And the damage it caused as a coroner when he himself was present for over 20 years, and how he witnessed it. And I know this helped awareness and provoked change in our attitude to bin drinking as the norm, and good crack cannot be acceptable anymore. So where do we go, or how do we stem the tide of self-destructive behaviour? I feel we're losing the close-knit support in communities because of families being broken up and mistrust among people, lack of faith in religion and church, and a reduction in social interaction. And there have been many organisations and support set up in recent times in order to stem the tide of suicide. And indeed, funding has been allocated by the government, as we have previously mentioned. Many documents and strategies have been produced. However, many recommendations in these documents have not been implemented and all end up on the shelf. So it's important to avoid duplication in various support groups and to coordinate them in responding to the crisis which follows suicide. So this has happened in County Mayo and the Mayo Societal Liaison Group, and it is working, a clear pathway for families and sufferers to be referred to mental health professionals in a team framework by their own GP and Gardaí. This could be repeated nationally or replicated. So as a conclusion, I'm sorry I'm running over time, but I thought I had my facts in time. But as a GP and a coroner, it's clearly apparent to me personally the vital importance of the personal contact we have with our patients, how crisis intervention in the consultation can make a difference to a person's life, prevent potential death, whether intentional or not. It is a matter of life and death encounters on a daily basis that we deal with, that decisions are made to intervene, to prescribe and refer accordingly. The doctor with a finger on the pulse can make a difference. Anything that interferes with that autonomy, be it pressure of time, lack of resources, will have a negative effect on patient care now and in the future. So listen to the voices of those of the coalface and health providers as well to invest in those areas. Skill and to acknowledge the skills and the fact that poverty and social deprivation are a major cause of ill health and early death. And until those issues are dealt with, no progress can be made. Thank you very much.